Good day. My name is Michelle Levander, and I'm the director of the USC Center for Health Journalism. Thank you for joining us today for our Health Matters webinar, The Youth Mental Health Crisis. The massive disruptions and losses of COVID-19 have plunged young people into a mental health crisis, leaving pervasive trauma and grief in its wake. The pandemic accelerated what was already a dire situation for America's youth, who are struggling in schools and at home. In the decade preceding the pandemic, suicide rates among young people aged 10 to 24 increased by 57%, and the rates have been rising fastest among Black youth. More than 1 in 3 high school students reported experiencing persistent feelings of sadness and hopelessness before the pandemic. Unresolved trauma is the most significant predictor of suicide, and many seemingly intractable societal issues, including domestic violence, community violence, and sex trafficking, can really begin with child trauma. Acting now to improve outcomes for kids will have long-term consequences for them, for communities, and for the country. Today, we'll talk about the forces driving so many young people to despair and the policy choices fueling the crisis, particularly in low-income communities of color. We'll talk about how journalism can help and how it can sometimes exacerbate the situation. We'll look at possible paths forward, as well as the ethics and sensitivities around reporting on children in crisis and their families. We have 3 distinguished panelists joining us to discuss all this. Dr. Julie Kaplow, the Executive Vice President of Trauma and Grief Programs and Policy at the Meadows Mental Health Policy Institute. She's the executive director of the Trauma and Grief Centers at the Hackett Center for Mental Health in Houston and the Children's Hospital in New Orleans. She's also a professor of psychiatry at Tulane. She's a licensed clinical psychologist, and she oversees the development and evaluation of treatments for traumatized youth. She's also CEO of the Lucene Center, a group practice that provides no-cost telehealth therapy to youth across Texas and Louisiana who've been exposed to traumas and loss. Dr. Kaplow and her teams are currently assisting in coordinating the mental health response for children and families in Uvalde, Texas, following the Robb Elementary School shooting. I also want to introduce Dr. Michael Lindsay. He's the Dean and Paulette Goddard Professor of Social Work at NYU Silver School of Social Work. He's a noted scholar in the fields of child and adolescent mental health, as well as a leader in the search for knowledge in and solutions to generational poverty and inequality. He leads the working group of experts supporting the Congressional Black Caucus Emergency Task Force on Black Youth Suicide and Mental Health, which created the report, Ring the Alarm, the Crisis of Black Youth Suicide in America. Dr. Lindsay is an Aspen Health Innovators Fellow, a Distinguished Fellow of the National Academies of Practice and Social Work, and a Fellow for the American Academy of Social Work and Social Welfare. And we'll also hear from Abigail Kramer, a journalist in New York, where she writes about public policy and its impact on vulnerable people. Most recently, she's been writing about children and access to mental health care for ProPublica and the City. Before that, she was the senior editor at the Center for New York City Affairs at the New School, where her work led to policy reforms that increased oversight of the city's child welfare, juvenile justice, and early education systems. And Abigail's reporting on mental health and children in New York is already prompting a very robust policy response. This webinar is made possible thanks to the generous support of the Christy Hammond Fund for Health Journalism, as well as individual supporters like you. We'll be archiving this webinar later today at centerforhealthjournalism.org. Just want to share a word about our format today. We'll be hearing from our speakers first, and then we'll turn it over to our audience for questions. Please feel free to share general comments in the chat. Because we have many people joining us on Zoom, we'll ask you to write your questions for our speakers into the Q&A panel. You can also write us if you're experiencing technical problems. Now, let's get underway with the topic at hand. Dr. Kaplow, we're here to discuss increasing rates of depression, anxiety, and suicidal behavior among young people in the US. But as we get started, let's just make sure we're all on the same page and understanding some of the basics. Help us with a kind of baseline. What is trauma, bereavement, and grief? These are not new problems. So please help us understand how the pandemic has exacerbated youth trauma and the youth mental health crisis.
Thank you, Michelle, and thank you for having me. I'm really honored to be part of this outstanding panel. And what I'm going to do is I'm going to share my screen and just show a few slides that I think will help to address what you just mentioned. So, when we're talking about childhood trauma and grief, I've really been referring to this as the silent epidemic of childhood trauma and grief. And that's because so many of the mental and behavioral health struggles that we see today are really rooted in traumas and losses. And I'm going to share a little bit more about that with you today. First, I just wanted to tell you a little bit more about the Trauma and Grief Center, which again, we have 2 trauma and grief centers. One is at the Hackett Center in Houston, which is part of the Meadows Mental Health Policy Institute. The other is at the Children's Hospital, New Orleans. And we have 4 main pillars with the Trauma and Grief Center. The first is that we develop evidence-based interventions for kids who've experienced any kind of trauma or the death of a loved one. We conduct training in the community with school and community-based clinicians and other providers in trauma and bereavement-related topics, including how to use the very same interventions that we use, because we know we can't do it all and we need to empower communities to be able to treat kids appropriately. We also do research looking at children's needs and strengths in the context of trauma and loss, as well as how effective our treatments are. Are they working for different populations of children? And if not, why? And then we also do a lot of policy work. So we make recommendations based on what we know of trauma and grief-informed best practices. So in other words, if a child in the United States experiences a trauma or a loss, how do we make sure that they receive best practice care where they're most likely to be seen, which is often in the schools, and we'll talk more about that. So just to make sure we're all on the same page, when we're talking about a trauma, this is the experience of a real or perceived threat to life or bodily integrity, or the life or bodily integrity of a loved one. And this is what causes an overwhelming sense of terror, horror, helplessness, and fear. And the key word here is perceived threat. So what is traumatic to one person or one child may not be traumatic to another. So that's a very subjective experience. And there are different types of traumas that kids can experience. Some are acute, meaning that hopefully they only happen once. But many times we're seeing chronic traumas. These are traumas that go on for long periods of time. And sadly, in our under-resourced communities, we see the cumulative effect of both acute traumas and chronic traumas going on all at the same time. And in fact, we know that about 2/3 of US children will experience at least one trauma by the age of 16. So we know that this is a very significant public health issue. We also know that there are some dire consequences of not treating trauma. So we know that for kids who experience chronic traumas, they tend to have smaller brain volumes. They're more at risk for depression and suicide. We see more school problems, problems with peers, violent behavior, as well as the intergenerational transmission of trauma. So this really speaks to the need to identify kids as early as possible after a trauma or a loss and get them the treatment that they need. And Michelle, you alluded to this earlier. What we know is that society's most significant problems, including those you mentioned, domestic violence, community violence, mass shootings, stem from unresolved childhood trauma. So again, speaking to the need to intervene early. The other type of trauma that I want to just touch on for a minute is bereavement. So this is actually the most frequently reported type of trauma in clinic-referred youth. It's also the most common form of trauma worldwide, and now even more so due to the pandemic. So now we're up to about 250,000 children who've lost a caregiver due to COVID in the US. It's the most distressing form of trauma among adults and youth in the general population. So if you were to ask anybody, what is the hardest thing that's ever happened to you? The vast majority would say it was the death of so-and-so, the death of my mother, my brother, or so and so on. It's also the strongest predictor of poor school outcomes above and beyond any other form of trauma. This was a study that was conducted by one of my former postdoctoral fellows, Ben Osterhoff, where we found out of 10,000 students that the strongest predictor of poor school grades, school dropout, school truancy, lack of school connectedness, problems learning, were a result. Sudden death was actually the strongest predictor of those outcomes, sudden death of a loved one, above and beyond any other form of trauma that includes sexual abuse, physical abuse, witnessing violence. So again, this speaks to the need to really educate the educators, our schools, in being able to identify kids who are bereaved as quickly as possible. We also know that there are some interventions that work and work effectively in reducing many of the psychological problems that stem from trauma and loss, including post-traumatic stress, depression, and suicide risk. One of those interventions that we've been using and disseminating widely is called trauma and grief component therapy. And the beauty of this intervention is that it can be readily tailored to the needs of different children. So for example, the second module is all about trauma processing. The third is all about grief processing. If you have children coming in where there's only been a trauma and not a loss, you can just use module 2. And if it's only been grief, you can use module 3. We've been successfully utilizing this in different school settings, including now in Uvalde. So this is an intervention that has been used after disasters like Hurricane Harvey, after school shootings like the Santa Fe school shooting, Columbine, now sadly Uvalde. And again, the reason that we've seen sort of an uptake of this intervention is because it can be readily tailored for school settings. It can be used in groups, and it can also be used individually and through teletherapy. In the trainings that we do, we bring together 60 to 80 community or school-based clinicians. We train them in this intervention. We send them out in their respective settings to do the work while providing a full year of ongoing consultation. And what that does is that it equips people to feel confident and comfortable with the intervention. It's sustainable, and then hopefully it continues over the years. The other intervention and program that we're very focused on right now is called the Handle with Care program. And the background for this is that we know that there are several keys to effective intervention for trauma-exposed youth. The first is early identification, as I've been talking about, in the immediate aftermath of the trauma, meeting kids where they are, which is most likely in schools. This is where so many kids receive intervention. And then enhancing communication between law enforcement, schools, and mental health providers. What happens with this program is that if a police officer goes to a scene where a child is present, so whether it's a homicide, a suicide, death of a loved one, domestic violence, that officer has a streamlined way to get in touch with the child's school and send a Handle with Care message. Basically, the message is, handle Johnny with care. They give the child's name, the date of the event. The school then contacts the child's primary teacher, alerts them to the fact that this is a Handle with Care student. The teacher then monitors that student for a couple of months to see if they're exhibiting any behaviors that would be indicative of the need for mental health care. And if they see any of those behaviors, the child is immediately referred for intervention, either within the school or with a community behavioral health provider. What this does is that it helps both law enforcement and schools become more trauma and grief informed. And it also identifies kids in the immediate aftermath of the trauma. And the reason we find this to be so important and the reason we're passionate about it is because we know that so many of these mass shootings have taken place after police have been to a perpetrator's home. For example, police visited the Uvalde shooter about 8 times at home before the shooting took place. Similarly, we're seeing trends like that with the shooter in Parkland. So again, the more we can intervene early, the more we can identify these kids as quickly as possible, the more likely we are to prevent these kinds of tragedies from going forward. I just want to mention just 2 resources. Our Trauma and Grief Center has a virtual learning library where we have freely downloadable webinars on different trauma and grief related topics, as well as handouts for caregivers, teachers, and others who are working with children who may have experienced losses. One of those resources is called The Power of Parenting, and these are handouts for caregivers who are trying to help their grieving child for different reasons. So grief due to loss of a loved one due to suicide, due to drug overdose in the context of COVID. So those are there for caregivers and other adults to utilize. And I will stop there.
Thank you so much. I'm going to turn to Dr. Lindsay. You've documented the increase in suicides among Black and Latinx youth. Can you unpack that for us? What trends are you seeing? What are the risk factors and the systematic issues that are driving this crisis?
Absolutely, Michelle. So on mute. Thank you for having me. And I really admire the great work that the Center for Health Journalism at USC is doing. Sorry, you'll hear sounds from New York City in the background, but let me share my screen and let's get going here. All right, so what we know about youth suicide, and I just kind of want to set the context a bit and then move specifically into the work that we've been doing with unpacking what's happening with Black youth. What we know is that suicide is the second leading cause of death among 10 to 19-year-olds in the United States. And actually, when you look at the differential data for 10 to, let's say, 14 and then higher, it actually is really acute among the younger age youth. In 2019, on average, those who were in the 9th through 12th grade, there were 3,703 suicide attempts per day. In 2019, that's data for which the latest year of data were available. And then from 2019 to 2020, there was 31% increase among youth who are showing up at ERs with some kind of self-harm behavior. Christina Caron, who is a really, really incredible reporter, documented for the New York Times a study that we did that was led by Ariel Sheftal last year, looking at Black youth, in particular, looking at precipitating circumstances that occurred prior to their suicide. And this was really rare because oftentimes we don't know what those precipitating factors are. And we looked at youth, Black youth in particular, from ages 5 to 11 years old, 12 to 14, 15 to 17-year-olds. So 3 different age groups within the population of Black youth, using data from the CDC. So 2 data sources, WSCARS and MBDRS. These are death reporting systems that are based at the CDC. And this was actually one of the first studies to document these precipitating trends and circumstances among Black youth. Girls, and this is what was captured in the New York Times article, Black girls actually saw the largest annual percentage change in terms of suicide increase. We typically think that suicide is a male phenomena, certainly a white male phenomena, older white male phenomena. But what's interesting is that among the population of Black youth, we saw that girls actually saw an escalating risk for suicide. What that might be related to is that girls are using potentially more lethal means by which to attempt suicide. What we also found was that among the 15 to 17-year-olds, they were more likely to have associated with their death the report of a relationship challenge. And that relationship challenge occurred 24 hours prior to a suicide attempt or the death related to suicide. And this tended to be more reflected among Black girls in terms of that relationship challenge that precipitated perhaps their suicide. And so I'll end in a few moments talking about what I think can address that particular issue. So I continue here. And then again, Christina Caron focused on yet another article related to the research that we've been doing around Black youth suicide, looking at the trends. And what was chronicled in this second article by Christina was work that we had done related to looking at an arc of time from 1991 through 2017, looking at CDC data, the Youth Risk Behavior Survey, which is a nationally representative survey administered every other year since 1991 to high school age youth, which is the sample we used in the United States. What was interesting about that particular study, which was published in the journal Pediatrics, we found that almost 20% of kids reported over that span of time that they were thinking about suicide, and almost 15% said that they had a suicide plan. And what I was interested in, along with my colleagues, in terms of the study, was looking at the trend in suicide behaviors over time. We looked at 4 indices of suicide behaviors that are thinking about suicide, planning suicide, a suicide attempt, and then having an injury related to a suicide attempt that required hospitalization. And so youth were asked and gave their self-report of experiencing one of those indicators of suicide. And we looked at racial and sex differences over that span of time. And the major finding was that we found for Black youth over that span of time, again, the years 1991 through 2017, there was a 73% increase in suicide attempts. Yet for every other racial and ethnic group, there was a decrease in suicide attempts over that time. Let me repeat that, a 73% increase only for Black youth over that span of time, while every other racial and ethnic group saw a decrease. And then in my lab, we looked at data from 2019 and found that there was a 144% increase for Black youth over that span of time. And for every other racial and ethnic group, there was no statistically significant finding of an increase in suicide attempts for that span of time from 1991 through 2019. Again, from 1991 to 2017, we saw a 122% increase, mainly for Black boys, regarding a self-reported injury related to a suicide attempt. And again, adding data from 2019, we found a 166% increase, primarily for Black adolescents over that span of time. So this led us to sort of try to figure out why there might be an increase. And so for Black youth in particular. And so I'm going to just share some what I frame as sociocultural factors. And I'm going to talk about 3 of those factors right now that might be related to the uptick in suicide behaviors and suicides. So one factor is there are barriers to treatment. And what we know in many minoritized communities, that there is a lot of stigma related to mental illness and treatment, that there is a tendency to want to handle problems within the family. Oftentimes kids might receive messages about not taking what has happened in the family or in their personal lives into the public sphere and talking to strangers, people that don't know your circumstances, about, talking to them about those issues. There's a lot of distrust of service providers. And let me just say this, because I'm a clinician myself, the distrust of service providers is perhaps warranted, because as a service provider, we can do a lot more to frame the services as inviting and welcoming to minoritized populations. And oftentimes there's misdiagnosis related to mental health issues. And just to expand on that a bit further, when a study in 2015 came out by Jeff Bridge and colleagues, indicating that for the 5 to 11-year-olds, that Black youth had the highest risk for suicide, I was invited to, along with some colleagues, to write a piece about why that could be happening. And I framed the title, Boys Don't Cry, but they do cry. And the question is, are we listening to their cries? Are we attuned to their cries? And so what we know is that in a lot of minoritized communities, we rear Black and brown children differently. Oftentimes boys hear messages about man up, fight it off, be tough, get back out there on the field. Certainly that happens for boys as well, irrespective of race, ethnicity. And then Monique Morris also talked about in a book called Push Out, what's happening with Black girls in terms of their experiences with being suspended or expelled from school, typically for matters that are underlined by a mental health issue, but the presentation of the behavior, if it's aggressive or assaultive, perhaps verbally or physically, school personnel are not asking kids about what is underlying that anger. The tendency is to suspend those kids or expel them from school, which is the second point, is that in terms of externalizing behaviors, they're viewed as antisocial or being deviant, and they might mask depression and other kinds of internalized issues like trauma or anxiety. I once interviewed a Black kid who was very depressed in one of my studies, and he said to me, when I'm sad or down, I want to go and knock somebody's head off. And so what we know then is that youth who have depression oftentimes might exhibit that depression in anger or explosive ways. Another factor is related to that, which is that Black and brown youth tend to disproportionately experience discipline. And so this is a study from the Department of Education that found that Black youth relative to white youth tend to be overrepresented with respect to disproportionate discipline, boys relative to girls, and then kids with disabilities tend to be overrepresented with respect to disproportionate discipline. And this is really a fascinating study by Lisa Janetian, a colleague who's now at Duke, formerly here at NYU. But she looked at behavioral infractions and the time of the month where there was an uptick in behavioral infractions in a school district that was primarily a minority school district, and found that there was an uptick in behavioral problems at the end of the month and was associated with income instability. And in particular, that kids and families reported that they ran out of food stamps. And so matters of food insecurity are associated with reports of behavioral infractions and the uptick of those behaviors toward the end of the month. And how many times do school personnel or other folks who are working with kids stop and try to understand whether the behavior is underlined by food insecurity, or there's been studies suggesting that when you put a washing machine or a dryer in schools for kids to have clean clothes, that they show up and attend school on a regular basis. And it's those kind of matters that we often overlook. So a third sociocultural factor is hopelessness related to trauma. And we all know George Floyd and that horrific encounter he had with law enforcement. And there's a study out of Harvard that was published in Lancet a few years ago that reflected, if you live in the vicinity of a police-involved shooting of a Black person and you're Black, you're more likely to report more days of psychological distress than if you are a white person who lived in the vicinity of that shooting of a Black person. You're likely to report no days of psychological distress. So there's vicarious trauma that I think has played a role in terms of what kids and families are experiencing and could be related to the uptick in terms of suicide behaviors. These are plausible explanations, and we need to document this further through empirical research. So that first point that I talked about, and I'm going to close out with a couple of points here, that social emotional learning standards are not required from K through 12th grade. And I talked about the 15 to 17-year-old Black kids who had relationship challenges, particularly girls, and that precipitated their suicide. It could be that if we expanded social emotional learning standards from K through 12th grade, and not just pre-K through like 3rd grade, in terms of what the majority of states within the US are actually giving kids access to that kind of curriculum, we could expand opportunities for middle schoolers or high schoolers to have access to the kind of curriculum that will help them to better articulate their emotions, or to sort of ask for help, and have resolution to relationship challenges that don't warrant or lead to self-harm behaviors. And then the other policy imperative, I think, is really important, that every school should have a mental health provider, and it should be proportionate to the number of students in schools. And for too many Black and brown school kids in school, they are going to school where there's no behavioral health support in that school, or if there is a person, that person is there only 2 or 3 days a week. And it oftentimes is the case that it's disproportionate to the number of kids in schools. And so that's the biggest policy imperative, I think, that we can do to really address the issue of giving kids greater access to behavioral health, mental health supports that would perhaps stymie this trajectory of increasing suicide behavior engagement. So thank you, and then I'll close it out here.
Sorry. Thank you so much to Dr. Kaplow and Dr. Lindsay for helping to really frame this, and offering up some ways that we can really try to start to address this momentous issue. I want to turn to Abigail now to talk a little about journalism and the kind of role that reporting can have in really bringing some attention to perhaps some of the policy failings that we're seeing on the arena of mental health care services for young people. And so, Abigail, you've reported in depth on the defunding of mental health services in New York at a time when they've been desperately needed. Tell us a little bit about what got you onto these stories and some of your findings, and what they suggest to you for reporting, avenues of inquiry for reporting elsewhere in the country.
Sure. Thanks so much, Michelle, and thanks so much for having me on this panel, which so far has been absolutely fantastic. So what got me onto this story, or this whole sort of line of reporting, actually was talking to providers. I started out with an opportunity to connect with and talk to a pretty wide range of mental health care providers, including people who were working in community-based clinics, people who were running programs in hospitals, people who were working with kids in foster care in New York. And I definitely did not immediately land on a cohesive line of reporting, but what I heard was this near universal sense of outrage, right? Everybody I talked to seemed to be seeing kids who did not have enough access to care, kids who were suffering needlessly, kids who were showing up in hospital rooms or hospital emergency rooms after years of under or poorly treated mental health problems, that in these providers' views never had to escalate to this level had they had meaningful and real access to care. And what was helpful about that sort of anger, that sense of outrage that I was hearing from experienced providers, for me, was that it helped me focus on questions of accountability. Because while people were talking about different specific issues, everybody was mad at New York State, right? So New York State licenses and regulates most of the mental health programs that operate. They set the reimbursement rates for Medicaid reimbursable services, which covers a large number of kids in New York State. And I got a really consistent and cohesive message that the state was underfunding services and was making it very difficult for kids to access care that they were entitled to. So that was helpful to me, because I do feel like there has been a really, really good increase in reporting that brings awareness to the fact that there are under and untreated mental health problems among a large number of kids across the country. And I really think that there's been a lot more focus on that in journalism throughout the COVID-19 pandemic. But it was helpful to me to keep being reminded that there are also accountability issues here, right? That this is not a crisis that came out of nowhere, that there have been years of deliberate policy and funding decisions that created the conditions for this crisis. And then this took me a long time to put together, but eventually also realizing, well, there are pretty specific state and federal laws around the mental health care that is supposed to be available, particularly to people on Medicaid. And you could make a pretty good case that this lack of access to care that seemed to run up and down the mental health continuum, presented a violation of those federal and state requirements. So that was really helpful. I also was very fortunate, I called a lot of people and landed on some really incredible networks of families and parents that were supporting one another. And they proved incredibly willing to connect me to one another, to tell me their stories about their experiences of trying to deal with mental health crises for their kids, of trying to access services. And there I was also, again, really fortunate to be able to speak to a real range of families in terms of what resources they had to bring to the situation, right? We're talking to very low income families who were dealing, in addition with a mental health crisis, housing instability, food instability, navigating the child welfare system. I was also talking to middle class, upper middle class families who didn't necessarily have an additional crisis except for this incredibly painful mental health crisis. And what was in common there was this near universal sense of desperation, that they could not get the help that they needed, that none of them felt that they were being treated really with respect by the mental health system. They didn't know where to go. And again, this was hard as a reporter. Felt like there were so many threads and so many things that were really, really, really bad. It took me quite a while to kind of land on a cohesive line of reporting. But ultimately what helped me was really to start digging through the data. I was not particularly familiar before this project with what states have to report in terms of the provision of healthcare services. And what I learned is that they actually have to report a fair amount on service provision for Medicaid recipients. And ultimately, we were sort of able to narrow down to this finding, which was that New York State has deliberately shut down hundreds of psychiatric hospital beds that are state-run for children and adolescents in mental health crisis. At the same time, the state has starved out hundreds of beds in residential mental health programs that are run by nonprofits that operate largely on Medicaid reimbursements. At the same time, the state was explicitly promising through its Medicaid redesign process to massively expand access to community-based mental health care for kids and adolescents. And this part was a little confusing for me because everybody I talked to said, yeah, that's a good thing. We don't want to be reliant on hospital beds. We don't want to be reliant on residential programs. We want money to be reinvested into community-based programs that meet kids' needs earlier. But what became really clear digging through a whole lot of published data is that the state was in fact closing down the residential beds, closing down the hospital beds, and not actually creating this new and massively expanded access to community-based care. So that was the primary finding sort of for this line of reporting for the city and ProPublica.
Abigail, maybe you could just quickly mention or address 2 points. One, what the Attorney General of New York is doing now in response to your reporting, and 2, just your broader suggestions on data for reporters in other states who want to try and do something, similar examination.
Sure. So yeah, the Attorney General, Letitia James in New York, has taken a really proactive role in investigating access to mental health care issues. Right now, she is holding a series of forums throughout the state to really hear from families and providers about the problems. She's put out a specific call for families who have not been able to get the intervention that they need in emergency rooms, right? So one thing that I heard from families and also from providers is that it's not uncommon for families to show up at the emergency room and possibly not even get evaluated, which I think the Attorney General is investigating as, a potential legal violation. The bigger context to that, right, is that I think there's nowhere to go for kids and families who are in acute crisis, right? The only place that families know to go is emergency rooms. The role of emergency rooms, as has been explained to me by, doctors who work in those settings, is to evaluate and potentially do inpatient care for kids who are at imminent risk of harm to themselves or to others, right? A lot of kids don't fall into that category. There aren't enough beds anyway. So hospitals don't necessarily have a role in the treatment of kids who are in acute crisis, but not at imminent risk of harm to themselves or others. So what families feel like is just crisis after crisis after crisis after crisis. Your kid is in acute crisis. It's utterly terrifying. It's incredibly painful, right? There's nowhere to go except an emergency room. An emergency room sends you home, right? And ultimately, families get tired of hearing like, oh, well, this is the criteria for admission. There's nowhere else for them to go. So that seems to be one of the focuses of the New York Attorney General's investigations and lines of inquiry here. I think it'll be really interesting to see how that shapes out. In terms of data, yeah, I think that reporters should spend more time looking at what is available. My experience is that it was very difficult to get a lot of comprehensive data on what kind of services kids do and don't get when they have commercial insurance, but that there is in fact a significant amount of data that states have to report to the federal government about what services kids do and don't get who are on Medicaid, and that's true for adults too. It's just not the data I was looking at. So I think it's really worthwhile to figure out, what does your state have to report to the federal government? What format does it get reported in? How can you get your hands on those documents? In New York, frankly, a lot of it is actually published online. It's really, really, really painful to dig through. And I never again want to think about how many hours I spent actually trying to make sense of these data sets and put them together in a way that actually sort of merged into any kind of coherent narrative. But it's a pretty rich, there are rich veins of information there. And I think it's worth digging into if what you want to do is really look from an accountability perspective at like, what are kids entitled to? What are adults entitled to in terms of mental and psychiatric care? And what are they actually getting? And what are the trends over time?
Thank you, Abigail. I want to just, before we open it up to our audience for questions, and just a reminder that we have this Q&A part of our Zoom where you can enter questions. We have some already. I just want to invite all of you to come back to this question about schools, because we've talked about how schools are a really important place for a mental health intervention. And Dr. Kappler, you have talked about this idea of connecting reporting by police of incidents at home with schools and letting schools know about that. And Dr. Lindsay, your research has suggested that schools, if they're not doing a good job, can actually escalate suicide and mental health challenges for youth. And so I just wanted to ask each of you to talk about both the potential and kind of the peril for schools to maybe exacerbate these issues. So maybe both of you can take that question, and then we're trying to open it up a little more broadly.
Sure, I can take a stab at that. And then I'm eager to hear Dr. Lindsay as well. So, one of the things that we're finding is that schools are so critically important in terms of early identification. And what I mean by that, and Dr. Lindsay sort of spoke to this briefly, is that many times when children have experienced a trauma or a loss, the first place that they're noticed or identified as struggling is in the school. And the problem is that many kids who experience trauma look as though they have attention deficit hyperactivity disorder, or they look like they have conduct disorder, or they look like they have, behavior problems, because that is often how the trauma is manifesting in children. Sadly, these kids are more likely to be misdiagnosed if they are youth of color. So we know that youth of color are often labeled early on as behavior problems, as having conduct disorder, without asking the right question of what may have happened to you as opposed to what's wrong with you. So often we hear from teachers, what's wrong with that kid? But the reality is their environment has created a situation where they are being reminded in the classroom of something very tragic or traumatic that happened. They're being triggered, and then they're escalating. So they're becoming really dysregulated in the classroom. No one knows why. And so that's why we really feel strongly that the Handle with Care program can act as a buffer to that. So if we know firsthand something happened last night that was potentially traumatic to this child, let's respond sensitively, and let's have the teacher monitor to make sure that we're getting that kid the treatment they need as quickly as possible. That is one really important step toward making sure that they don't get mislabeled and misdiagnosed early on. I also think that there's real opportunity in the schools to provide services. As one example, we are working closely with the Dallas Independent School District to train all 500 of their school counselors in an evidence-based intervention for trauma and grief that can be used in group settings. They came to us because of the number of COVID-related deaths that their kids have been experiencing. And that's interfering with their schooling. That's interfering with their ability to focus and to concentrate in the classroom. And so now we are, launching this large-scale learning collaborative for all the school counselors, and we're also training all the teachers so that we can have a streamlined referral system. So if a teacher recognizes this is a child who's experienced trauma or loss, they're coming to us having mentioned that their grandparent, their caregiver died 2 days earlier because of COVID or whatever it is, they can get into those treatment groups quickly. And so I think in addition, and Dr. Lindsay mentioned this as well, there are ways to ensure that we're using tiered models of care in the schools so that, there can be a group that's focused just on basic coping skills. How do you deal with stress? How do you deal with, emotionally disruptive things that might be happening in your life? Those can be implemented in classroom settings. And then in addition, we have the school counselors providing that higher level of intervention. And that's exactly what we're rolling out now across the Uvalde School District to make sure that any child who's struggling for any reason receives the best practice care that they need in the school setting.
And Dr. Lindsay,
Yep.
would love to get your thinking on this too, and just this idea, this model of finding out from police about an incident, but even just other aspects of this idea of how schools can help or harm that we didn't touch upon before.
Yeah, so I want to be careful and say that I don't mean to intend or indicate that schools are escalating the suicide behaviors that we're observing. What I want to say or intend to indicate here is that I think that I want to be careful with my words. We could be doing more to support kids, and Dr. Kaplow just said it. We could be doing more to support kids around providing access to mental health services and supports. Now, at the same time, we have to work on ways to make sure that those services are culturally attuned and appropriate. Just because you build services doesn't mean the kids are going to show up. But I'd like to see more of that kind of response to, behavioral health or behavioral concerns, as opposed to being, sort of more firm around suspending or expelling kids from school, or that we need more law enforcement in the schools. I think that it basically, sort of blames kids for, the challenges with which they present, and doesn't reflect the important perspective around the context that shapes their experiences. So food insecurities and other kinds of challenges. I think also Dr. Kaplow talked about the community context in which there is, sort of traumatizing events that kids bring into the school. And, without any place to kind of take that or resolve it in a healthy way, it could manifest as, volatility, anger and that sort of thing. And, taking stock of what might underlie that, where a trained professional can get at that sort of perspective taking is really important. And I think in absence of that, kids are not able to take their challenges to a place of resolution. And so it could be that pain turns inward, and that's why we're seeing the uptick. Now, this needs to be empirically validated, right? But we do have a study that shows that when kids receive mental health services and supports early in their lives, that it does reduce the likelihood that later they will engage in suicide behaviors, like thinking about suicide or attempting suicide. And so we do have a study on that as well. And I put my email in a response to a question. Folks can email me and I'll send the studies related to that. But I think that, listen, schools are the place now in our country where kids are receiving mental health services the most, right? It doesn't happen in a community setting as much as it happens in schools, right? So there are studies that have documented that. Schools are the largest provider of mental health services. And so that being the case, let's make sure that more providers are available in schools, particularly in schools where you have a higher representation of kids who represent historically marginalized populations. And let's make sure it is proportioned to the number of kids in schools so that everyone can have access to those supports when they need it.
Thank
I hope
you.
that makes sense.
Thank you. No, thank you. I just want to mention there's been a number of questions in the Q&A about Dr. Kaplo's work and that program. And so she's going to put that in the chat, as well as a few studies that are relevant to this conversation. And Dr. Lindsay, if there was one study in particular or two that you want to pop in there too, that would be wonderful. I want to turn to a really important question that Sonia Chopra asked, and that we did hope to touch upon before this our time together ended, which is if there's data on LGBTQ youth and what kinds of trends we're seeing for them.
Do you want me to take that on? So yeah, a couple of things. One is that most studies that I've observed do indicate that LGBTQAI youth are at higher risk for engagement in suicide behaviors, obviously related to lack of support, lack of appreciation, obviously of how kids are identifying, and the sort of painful, caustic experiences that those kids are subjected to as they come into their own identity in terms of how they want to be, reflected in the world, right? And so incredibly, problematic that there's not the requisite supports that are available to help, kids and families, sort of, come into whoever they, want to identify as, and to support that, right? At the same time, we do have a study that showed, to that point of lack of support for the LGBTQAI youth, that even kids who are struggling with their identity in the sense of they might identify as heterosexual, or might indicate that they typically engage in same-sex intimate relations, if they had a report of an opposite sexual relationship or intimate relationship, that the sort of discordance with how they identify and the intimate relationship they had in the past year, those kids actually have higher rates of engagement in suicide behaviors, to sort of reflect the point that I'm making, is that it's problematic that we're not supporting youth around their sexual identities and providing the opportunities for for them to, have the healthy identity with their families and loved ones in a way that supports how they want to be identified. And so there's a lot of work that we can do in schools and community-based entities and in minoritized communities, particularly if there's a strong faith-based component. There's a lot of work that needs to be done in those faith-based entities and churches to support kids in terms of how they want to be identified and received in the world. So I think there's a lot of work that we can do in that space.
Thank you so much. I want to turn to two journalism questions, Abigail, for you. One is, do you have any idea on how we can get data on pediatric psych bed availability? And the other one is about how did you find the families you work with in your reporting?
So I think the first question on like how you can find information on psych bed availability probably really varies. Probably really depends on where you are. I was fortunate enough in New York that the state had undergone an explicit Medicaid redesign process, which is incredibly fraught and problematic over the last decade, but did result in some accessibility. More numbers were available sort of through those reports that then led me on to, what's standardized reporting. For sure, your state has to report that information to the federal government in some way. So what I would do if I were approaching this question cold is I would try to talk to a hospital that runs a psychiatric program and figure out what they report to the state and in what format, right? Because there's going to be something that they're required to like do. If you can figure out what the name of that form is, you can potentially just put it in a Freedom of Information request for all of those. It's not going to be that many hospitals, right? That might be one way to add it up. But before you go down that road, I would really look hard at what is actually already available in terms of public reporting. I found that there was a lot more data than I expected, and that it was hard to find. Like there was no index of all of the numbers, right, on the Department of Health website. You had to do a lot of hunting around, especially in sort of places where the state was reporting to the feds, but those reports were actually available online to put those numbers together. So I wish I could give you a more specific answer, but I think it really varies state by state, but those numbers definitely have to be reported to the feds.
And did you want to answer quickly, just because we're short on time?
Connecting to families.
Mm-hmm.
Yes. Okay. So I went about that in two different ways. I was talking to a lot of lawyers who work with families, and I was talking to mental health care providers. And in some cases, they were willing to connect me with families they had worked with. That was much less productive for me than when I was able to connect with sort of either informal or formal groups of families that support one another. I found that parents who had sort of become advocates for their own kids and then become helpers to other families were absolutely the best people to help me understand how the system works and how you actually navigate it, right? And B, that once you sort of earned, and it helped that I wrote a series of stories so that I was able to earn a little bit of trust. That once I earned that trust, people were very willing to make connections and were incredibly generous with their time and their experiences in talking to me. That worked out a lot better. It's hard to be, it's the straightest line is to be connected by a mental health care provider. But, obviously it raises questions of indebtedness to the provider and always raises some questions of sort of control over that access. And, does their press person want to be present when you're interviewing the family, right? Are you going to be able to talk to them multiple times? So best bet, I would say, is connecting to networks of families who talk to each other, and they probably exist.
Thank you. We have a question from Scott Scanlon, who says, I'm a journalist in Buffalo, New York, who covers healthcare and family life. The mass shooting here on May 14th has had a ripple effect across the region, with those in surrounding neighborhoods of the top supermarket where the homicide occurred generally struggling with the most serious post-traumatic stress. What should teachers, administrators, parents, clinicians, and other adults look for in terms of the greatest indicators of stress? And I don't even know if that's the word you all would use, Dr. Lindsay and Dr. Kaplow, among kids and folks of all ages, and how can they best address them?
Dr. Lindsay, do you want me to chime in quick?
Well, I can say real quick, one of the things that we look for is change in functioning. And so if a kid or anyone is struggling with just an abrupt change in their functioning, whether that's in terms of academic performance or how they relate to others, withdrawn, et cetera, that's a sort of sign that a person might be struggling with something that warrants some attunement to it. So I'll just quickly say that.
And Dr. Capello, do you want to talk about the kind of ways to sensitively respond in that scenario? I think the second part of the question by the reporter. Thank you, Lindsay.
Yes, so this is a long topic. I would also just mention that for little ones, for preschoolers or young children, we also look for things like developmental regressions, if they're all of a sudden not eating or sleeping well, if they're excessively clingy with the caregiver, also social withdrawal in older children, so isolating, not doing things they used to enjoy doing. Certainly risk-taking behavior would also be another indicator. And of course, as I'm sure Dr. Lindsay would agree, any thoughts or comments about wanting to hurt themselves would be a major red flag. In terms of responding sensitively, I think one of the things we don't do very well in our society is address grief. Just as, we all struggle when someone loses a loved one to know what to say or what to do. I think the best thing we can do, especially in the schools, any adult who encounters a child who has lost a loved one, to be very open about it, to be able to say, I'm so sorry that this happened to you, to not try to ignore it or sweep it under the rug. I think bearing witness to a child's pain and being there to hear what they have to say is one of the best things we can do for children. So I know it's a difficult topic and it's really hard to bring it up, but we sometimes have adults concerned that if they bring it up, they're going to make the child more upset. What actually happens and what we've learned through our research is that the more we can talk about it openly, the more we can directly address it head on, the less distress the child feels. So that's one thing that I think we can do as adults when working with kids.
And I just want to mention, while our hour is officially up, all of our speakers have graciously agreed to stay on for a few minutes extra. And we'll see, I know there's many questions in this Q&A. We're not going to be able to get to all of them, but we'll try to get to a few. We have a question from Jennifer Brooklyn. She says, a positive deviance question. Is there a school district or system that any panelists are aware of that is doing something really right when it comes to serving kids' mental health needs?
I can just quickly say that, in our work with the Dallas Independent School District, they are highly attuned to what is causing kids to be, having difficulty in school. And a lot of that, again, has to do with the traumas and losses that they've experienced, whether due to COVID or community violence. And so one of the things that they're doing is sort of creating that continuum of care. So educating the teachers, educating the educators first about what to look for, and then rolling it out across the entire sort of behavioral health initiative that they have with all of their school counselors. And in addition, making sure that kids know who to turn to. So making it okay to talk about these things in a school setting and creating those safe spaces where kids can feel comfortable. We're also leading a program for the teachers there called the Teacher Champion Program. These are teachers who self-identify as wanting to be sort of supports for kids, certainly not becoming the child's therapist, but being there if a child is struggling to be able to help navigate that and get them to the right person. So I would say Dallas ISD is doing it right for sure.
I would offer that many school districts around the country, I know this started in Oakland, DC, certainly New York, are starting to do more restorative justice work. And that tends to be associated with a lot of success academically, as well as social and emotionally. And so restorative justice is really great. I know Lavone Robinson at DePaul is doing really great work in Chicago on suicide risk prevention, targeting ethnic minority youth, and has been successful in her funding from the National Institute of Mental Health to do this work. So those are some examples that come to mind for me.
So I'm seeing a bunch of questions here, and it's going to be hard to answer all of them, but that really try to ask how all this fits in with a broader context of systemic racism and oppression. And so I'm going to just read these questions out, and maybe in our remaining few minutes, we can try to just acknowledge them. I feel like we've talked about this during our time together, but I just am seeing these questions and wanted to share them with you. Ravi Chandra says, as a psychiatrist, the through line I see is the prevalence of abuse of power and its impact on journeys of identity, belonging, wellness, and meaning. Mental health is an important angle, but do you address that issue as well? And I'm just going to read these three. Yvonne Price says, does the Handle with Care program consider the historical cultural context of the relationship between police and Black and brown youth? And then Alexis Martin says, it's important that we ensure that we talk about disparities in health and mental health for kids of color and ensure we uplift data on the school to prison pipeline's negative impact on policing and its impact on young people, which leads to disparities in mental health outcomes. Can you discuss the data on this? These are enormous topics, but let's just try to touch upon them a little bit.
I can quickly address the Handle with Care program question. So yes, so the answer is yes, we have absolutely recognized that for many of these children, even seeing a police officer is a trauma reminder for them. And so what we've tried to do is build into the training that we've been providing law enforcement about that very topic and how, especially for youth of color, that police officers need to be readily aware of what they may represent for that child and how to respond sensitively to that. So what can they say to help ensure that a child feels comfortable, that they're an ally, that they're not trying to harm them? So that's a big part of the training that we're doing within the Handle with Care program in particular.
Well, I think that the study by Jacob Bohr and Lancet that came out in 2018 was really a definitive marker for me that when police are involved in shootings, killings of unarmed Black and brown folks, and you live in the vicinity of that, or even if you hear about it and you are a part of those communities, it has an impact on you. It's been framed as a spillover effect, vicarious trauma, and so the insidious nature of that, has a bearing on a lot of folks of color who are in those populations, and I think that it engenders a sense of hopelessness for kids, right? And so this needs to have further empirical validation, but it's a plausible explanation as to what is happening. And we could dedicate a whole other webinar conversation to this because there's a lot to unpack there.
And Abigail, did you want to add anything on this topic in journalism that tries to touch on this? It's a really big, I think, a challenging journalism question too.
I think it is a challenging journalism question. It's something that is, really hard to write about well, and also specifically. One thing that I hear from families, I've heard from families over and over as I've talked to them, is the way that sort of under and untreated mental health issues, which obviously, the traumas and the access to treatment have so much to do with both financial resources and race. But then also, once you're sort of in those systems, the way that families get pushed into other systems where really your outcome, your access, your power, your leverage has so much to do with both race and class. And that would be the child welfare system, right? I've talked to so many families who, because their kids are in crisis, there ends up being child welfare involvement. And then, sort of the level of fear that raises, and ultimately the outcomes in those systems have so much to do with race and class. And then also, kids in crisis interact with the cops a lot, right? So one of the things that I wrote about in a recent The City and ProPublica story was the fact that families have no choice often but to call the cops on their own kids, right? And just speaking anecdotally, particularly for Black parents, just how utterly terrifying that can be, and that they feel that they are specifically and directly putting their children in danger. But there's also no choice because there's no better option.
Yeah, thank you, Abigail. Well, I want to thank all of our tremendous panelists. I want to thank our audience for their excellent questions. I also want to thank our team here at the Center for Health Journalism. Fran Smith, one of our contributing editors, Ryan White, our content editor and project lead for our webinars, and Harold Pierce, who heads up our online outreach. And I did want to also mention that we have an upcoming webinar, and you have an opportunity to sign up early. It's going to be in October, and it's really a chance to hear from Dr. Anthony Fauci as he recently announced his retirement. I'm hoping that while he's never been shy, he'll be even more frank as we talk about another really important issue right now, which is monkeypox, and also looking at COVID and his reflections there. And he can be interviewed by Washington Post reporter Dan Diamond. You can scan this code to register, or we'll be sending it to you in an email after this program. We'll also be sending you a survey, and we encourage and invite your feedback on our time together. So I want to thank all of you for this excellent conversation. It's so important, and we hope to see some great journalism that results from some of these ideas. Thank you so much to all three of our panelists.
Thank you so much.
Thank you.